You've made it to stage 3, phase 4, professional value, communicating clearly and competently your professional value. This particular video and training is going to be a little different because I'm going to pull from a video I've already created at explaining your professional value. I wanted to first do a lead-in though and make sure that you know that this is completely connected to this section. We're still going through your Connect Mentorship Workbook, and I want you to take the time to listen to this coming video. This will help you provide clarity at how to properly communicate your value based on the population you're speaking to. Now I'm going to go ahead and read this so that you know that it's my voice and my heart that's delivering this message to you. You've made it to phase 4, communicating your professional value. During this phase, you will be reminded of the importance of words. The words you say are everything when it comes to your listener receiving the message you are trying to convey. Remember that any message you deliver is going to need to fight through noise of misunderstanding, unintentional ignorance, preconceived notions, poor experiences, and the list goes on. It's our job to be able to observe our patient's posture towards our therapy. It's our job to observe our patient's posture towards occupational therapy. You have to gauge the temperature of the room, always. You have to see how they're interpreting what you're saying. You can't just blow through it with an activity, or else, like my evaluation the other day, he said, I never would have thought to come to occupational therapy because the last person just had me make an egg. Guys, no, that stops here. How are you going to deliver our message? That is what we are going to be talking about. We need to stop promoting development and use of what I like to call the elevator pitch triad of despair. I talk about this a lot. The OT elevator pitch triad is this outdated and ineffective idea that when we describe occupational therapy, we must include the following words: occupation, meaningful, and functional. I have been defending my profession and scope of practice in many leadership positions for years, and I'm telling you from firsthand experience that we need to stop using these words because people view them as woo-woo. Woo-woo. You know what I'm saying? Stop it. Do not bring down the intellect of the profession by using those 3 words, because we have literally run those words into the ground over the past 20 years. We are facing an existential crisis right now because all we do is talk about this elevator pitch of despair, and it doesn't need to happen, okay? Now I'll step off my soapbox and get on with the message of professional value. But know that I'm very passionate about this. Communicating professional value should take into consideration the listener's current status. During the video for this phase, you will learn how to communicate your value to the public, professional peers, and patients. How do we explain occupational therapy to our professional peers? How do we communicate our value proposition to the general public? And then how do we communicate what we are offering to our patients? How do we effectively take our huge scope of practice and narrow it down into a nice little package so that somebody can digest it and say, oh, I see. I see. We go to school for so long to be able to offer a holistic, integrative point of view for rehabilitation services, right? A lot of us get into this field because we can do so much with our education. Wow, we learn both medical terminology. We're in the medical model and we take these medical-oriented classes. And think of gross anatomy, right? I took gross anatomy with physical therapists, students, right, and pre-med students. We're all in the same category. Second to that is we are one of the only professions that do take gross anatomy. Nurses don't take it, right? We know so much about the integrative human body, and we're able to apply both the medical POV, point of view, and the social POV, which is the environmental context and these contextual implications of a diagnosis or an illness or even just the aging continuum itself, right? So how do we portray this effectively to everybody around us so that they know we have a medical degree, right? We have a medical degree, we spend tens of thousands of dollars to get this medical degree, and we are competent restorative therapists that can treat the whole body. We are not just activities, right? But we fall into this pit because we learn an OT elevator pitch and then we go out into the world and we give them our OT elevator pitch, and then we're met with these blank stares, or our patients, after hearing our value proposition, we go in and say, hey, I'm your occupational therapy practitioner and I'm gonna do this, this, and this. And then afterwards they say, well, all I really want to do is get up and walk, right? We think that we effectively communicated our value, and still our patients the next day would rather have physical therapy than occupational therapy. That would tell you that you did not effectively communicate your value. Like if your patients still want physical therapy over you, you didn't do it right. Right? And let's just like call a spade here. I think at this point in our careers, at this point in this stage of our profession, right? We were the first ones on the playing field. We were the first allied health profession on the stage, and we are only now starting to really develop who we are. We've had this identity crisis, and everybody has seen it, and people have kind of exploited that, right? People are kind of starting to infringe upon it, and we'll get to that in today's masterclass. But what is the source of this confusion? Well, we're going to break down by population how we should be approaching it. But first, we're going to be very pragmatic. I'm a very pragmatic person. All of the examples I'm using are either personal experiences that I've had, so they're real. I'm not making them up or exaggerating them in any way. We also get a ton of messages and emails about stories that other people have experienced. So all of these things that I'm explaining to you are actually happening. They are the OT reality. And in school, your teachers aren't going to tell you this, right? Because they want you to feel like you can own the world. Well, you can. OT is awesome, but they're not preparing you to be able to own the world, because they're not, they're like equipping you with the OT, what do I call it? I call it the elevator pitch, the OT elevator pitch triad. What is the OT elevator pitch triad? It's when we use these three words in our elevator pitch: functional, occupation, and meaningful. Nobody knows what occupational therapy is. We really got the raw end of the deal with our name. It is what it is. We can't do anything about that, but we can do something about how we're explaining it. And why we always get praised in school for including the triad in our explanation, I don't know. Because when I began my journey and when I became a private practice owner, and I realized that, wow, people really don't care, or people really don't get this elevator pitch. They really do not get these words. They glaze over, they reject you. They're like, I don't need you. We're already referring to physical therapy. I don't really need that, right? Because they're so confused. We're like, we give these like diluted, very convoluted responses to what is our profession. And sometimes we even like go a step further and use other allegories or like metaphorical language to describe our profession when it's already an enigma. So we're going to address this today, remembering that I am just one perception, one perspective, one vantage point, and if you have a conversation with other practitioners, they will have a different POV on this, which is fine. Let's celebrate that as occupational therapy practitioners. But above all else, let's start advocating appropriately. So let's break it down today. Let's get real. Okay, so let's jump right into it. As way of overview, we're going to be discussing, like I had mentioned, we're going to be discussing how to explain the OT profession to the public, peers, so professional peers in our workforce, or even amongst our fellow peers in school, right? If you're a student, how are you going to explain what you are bringing to the table to other professions who are in school? And then finally, our patients and a note of encouragement. So at the end, I'm going to encourage you because I am going to be sharing very pragmatically. I'm going to kind of be just putting it all out there as far as stories I've heard, as far as firsthand experiences, remembering that as I stated, this stuff isn't exaggerated, right? This is the reality of our profession right now. And that's why it's so important to be able to communicate what OT is and what we bring to the table for any number of these individual people groups, right? So number one, explaining OT to the public. So the current predicament of the public eye, number one, is the associations. So when it comes to advocacy, associations kind of stick more to these macro level advocacy campaigns. So government, they are dealing a lot more with legislation than they are with actually making sure that people know who we are and what we do on the ground floor. So we need that too. I'm a supporter of my associations. I'm a member. I think that's important. You should be supporting your associations, whether or not you feel like they're helping or doing anything or can offer you any value. You still need to support that. So I've had a lot of conversations with many of you who have asked, should you still support your association if you feel like they're not doing anything for you? I think so, because they still have networks that you don't have. They are still advocating for us in the government sector, and they can still provide good resources, right, for us. So definitely those are, like, as far as our umbrella organizations, you should support them if you are an occupational therapy practitioner. Now, the other side of that, needs to be addressed as well, though, is that they are only, really for the most part, advocating either on that macro level, government level, or starting a discussion among other occupational therapy practitioners. So really, their influence is very closed, right? So while they send all these really encouraging emails, we may be fired from our job because they don't think OT is beneficial in that place. We're losing ground in outpatient. We're losing ground in orthopedics. We're losing ground in neurological affairs because nobody is understanding what we do. So our profession right now is facing an existential crisis, and that has been said at many conferences I've been at locally, because of the fact that it's great that we're advocating on this removed it's great that we're advocating on the macro level, right? But what about the micro level? What about the public? The message isn't being sent, okay? So that's kind of where we're at with the associations. I wish that they were doing more. A lot of us wish that they were doing more, and we complain about it, but there's nothing we can do about it. So it's up to us to make sure that when we are discussing who we are with the general public, we know how to communicate it, because change is going to start with us, right? The next one is other professions and organizations define who we are. That is happening. That is happening all over the place. Think about skilled nursing, for example. One of the reasons I left skilled nursing was because I could not stand being told what I could and could not bill for. I couldn't stand that other OTs were telling me, so people veteran to me, so people who were in the field longer than I, told me that, no, we generally do upper body and PT does kind of everything else, and this is what we do, and we'll do self-care. And then just recently, and you may be on the call, I had a consult with somebody who had mentioned that their administration at skilled nursing just sat them down and said they can only bill for self-care, and they need to be deferring
all therapeutic exercise and neuromuscular reeducation to physical therapy, people are actually telling us what our scope is, which is crazy because we are all autonomous licensed medical professionals. So to be told how to bill by people who don't know our scope of practice is kind of crazy, and nothing's being done about it. So that's a problem. And because of that, when people get out into the world, right, that's what the public is seeing. That's what the public is hearing. I have a local physical therapy clinic who like actively tells their patients that they shouldn't go to OT for lower body care, because OTs can't really do that. They should pick up more time with them instead of going to OT. Because my patients see results and they know my competence in the entire body, like they end up just quitting PT and coming over to us, because that's no good, right? That's no good that another profession is actively telling people what our scope is and getting it completely wrong. But that's what's happening on a public level. Okay, so these other professions are telling people and spreading the word that OT is like in this little box, when really we're very pervasive, right? Next, we're losing ground. We're losing our scope. People are coming in and kind of taking over those roles, and that's a problem. That's a real problem. So other professions are being brought in to take the place of an OT role because nobody knows what OT does, right? So that's another thing, is we're losing ground in the public sphere because nobody knows what we do. I have an example, perfect example. So when someone needs companion care, so when someone needs a assistance at home, they want to stay at home and they need somebody to watch, make sure that they're safe, or help them with self-care or what have you, they will go to these companion care places and have somebody hired to come in and sit for 4 hours at a time or whatever it may be. You know who's doing the initial functional assessment to decide how much assistance they need with ADLs and IADLs? Business managers, social workers. They are doing them. There's no OT that they even hire to do that. That's a problem, right? So the more people in the public see other professions doing what we went to school for and not even having an OT in the game, we lose ground exponentially. And then finally, the perception. On the public level, we are typified, right? Typified, what does that mean? It means that we fall into this box, into this role, and we can't seem to break out of it. It's oftentimes referred to actors or actresses that are constantly in the same type of acting role, right? They can't seem to break away from this box that they put themselves in, as they only do action or they only do romantic comedy or whatever it might be. Occupational therapy has found ourselves typified. What do I mean by that? I mean, when someone thinks of OT, they think of post-stroke needing self-care. They think just ADLs, IADLs in general. They think putting cups in cupboards. They think laundry. They think kids, or sometimes they think hands, but we're losing traction on that here too. In my area, there's one hand therapy clinic, and there's only a couple of them hired in a physical therapy clinic. Physical therapy outpatient has taken over all orthopedic, post-orthopedic trauma, orthopedic surgery, and that is becoming a trend. So thinking about how we can't even maintain our presence in one of our types, as in hands, we're losing ground there too. So that's a problem. That's the current public predicament. So what can we do about that? So then how do we present this to the public? How do we pitch or not pitch our OT value proposition? So the first thing to avoid is the OT elevator pitch triad. We've talked about this already. What is the OT elevator pitch triad? It's the when we say functional, meaningful, and occupation, and that's what we use in our 2-minute our 2-minute explanation of what we do. That's not okay. They're going to glaze over, and believe me, I have done hundreds of presentations to the public. I have been in private practice now for 5 years, and I have tried just about every pitch possible to refine my ability to communicate occupational therapy. So I have a little bit of experience with this, and I promise you that saying those 3 words will cause your listener, the person listening to you, to just glaze over. They're going to say, oh, that's really nice. That's really nice. But when they're injured, they're not going to come to you because they have no idea what those words actually mean. Those words don't mean anything to them. It's like a fluff. It's like fluffy, right? Using physical therapy in the same sentence. That's like one of the number 1 things we learn in school, right? Don't use physical therapy to explain occupational therapy. Don't do that because you're putting yourself second to another profession. You're literally confirming the problem in the first place. You can't even describe your own profession without leveraging the name of another profession. So that's a problem. So don't do that. Phrases that overgeneralize the profession, like, we help you do everything that is meaningful. What? What does that mean? That means like nothing. That literally means nothing. If I said, oh, what do you do? And they said, I help people do things that are meaningful to them. I'd be like, okay, that's nice. Is that a certificate you got? Or is that like just something that, like, did you go to school? Or is this like a side job for you? Like, is that you like a I wouldn't think that this person is a licensed medical professional who had to know competently gross anatomy, which means muscles, joints, nerves, the brain, the structures, the biochemistry, the neurophysiological components of human body movement. I wouldn't know that this person knows that if they said, I help you do everything that is meaningful to you. I wouldn't know that, and that's a problem, because if I don't know that about you, I'm not going to come to see you when I have an issue. I'm going to go to someone I know is competent, which unfortunately is kind of like physical therapy, right? So please do not overgeneralize the profession. It's no good. You went to school. Oh my gosh, I was talking to somebody about gross anatomy the other day, and we had 30 seconds to go from cadaver to cadaver and be able to pinpoint what nerve bundle was tagged, what muscle was tagged, what tendon or ligament was tagged, what part of a bony prominence was tagged. We had to know that for just one test. That's crazy. People should know that you know how to do that. Don't do that. Don't overgeneralize yourself. Phrases. So don't further confuse somebody. Don't use a metaphor or an allegory to explain your profession. You're a medical professional. Why are you using a metaphor to explain your profession? No. Using funny and undignified phrases like PT helps you walk and I make sure you don't have to walk naked. Like, what is that? That's so undignified. That is undignified. You're making fun of yourself. Please don't use that. Reducing OT to any one thing that feeds into a stereotype. So if you, and I've heard OTs tell their patients this, I do the arms and then physical therapy is going to, generally, I'm going to work on your arms and then PT is going to work on your legs and help you walk and get you moving. What? Or, I'm going to come in and I'm going to make sure that you can get dressed and you can, do grocery shopping and you can do all of that safely. And then PT is going to, do everything else. Or, saying we work with kids or whatever it might be. Don't be vague and don't reduce your profession to a word or even worse, right? Go right into that typification. So what should you incorporate? Some things that you should incorporate. Use what you do right now. You don't have to reinvent the wheel. Remember that this is a lot. Our profession is huge. When our founders of occupational therapy included both the medical model and the social model into our point of view, into our scope of practice, they took one profession and literally made it 3 professions in one. We're biopsychosocial. So we are 3 different professions in one. You're not going to be able to explain that in a shortened, condensed, nice little package. So start with what you know. What are you doing right now? Okay? Are you in peds? Explain peds. Are you in skilled nursing? Explain skilled nursing. Are you in outpatient? Explain what you do in outpatient, and do so competently. Use competent language. Don't use jargon. Don't don't try to make it fun and cute and put it together. I put the fun in functional or whatever it might be. Don't do that. Use competent language to describe what it is that you are trying to, or use competent language to describe what it is that you're doing, the science, the social and medical science behind what you're doing. You are a medical science that looks at both physical and non-physical factors of healing. So incorporate that into your explanation. You can work with well people. You can work with unwell people, right? You can work with the physical components of healing, but you also work with the psychological, the mental health, the perspective-based, and the social, contextual elements of healing, all in one. And then finally, use examples that the listener will understand. If that individual knows someone or has experienced in their own personal lives or family a stroke, use a stroke to help them see what you see. You cannot be too medical. I know in school they talked about how we have a different health literacy, right? We communicate differently. You can't use big words with people in the non-medical field because they just won't know. But honestly, at this point in 2021, people want to be spoken to as if they can let them make that decision, right? You don't need to dumb down our profession in fear of offending someone if they don't understand what you're saying. Okay, that's enough on that. Go ahead and let me know in the comments. What do you think? What do you think? Again, this is my perspective on it. My frustrations come out a little bit in these master classes because I'm very passionate about occupational therapy. I think we're awesome. I think we are so intelligent, and I just don't think we get enough respect. So be an advocate. Get started today. Hop on social media. Go on live once a month and talk about your profession. Talk about what you do on a daily basis. And don't lead with adaptive equipment. Don't do all these videos with reachers and sock aids because that's not OT. That is not OT. And every time you do something with a reacher or a sock aid or I don't know, if you only post things about ADLs, that's all anybody is ever going to know about you. And ADLs is not what OT is. Activity analysis in any activity that one does throughout their lifespan to remain independent, regardless of deficit, that is what you do. And you apply medical and social science to that in order to bring somebody through that continuum. That is what you do. You do not equal a reacher or a sock aid, okay? So don't advocate that. People will listen. And if we elevate our pitch, if we elevate our OT explanation, our credibility as occupational therapy professionals, it will also increase. So what are the biggest takeaways here? The biggest takeaways for advocating or explaining your OT pitch, if you've done it correctly, your audience, your listener, will know that OTPs are competent and restorative care of muscles, bones, nervous system, and mind. They will know that you are a whole body practitioner and have qualifications to work with all parts of human dysfunction. Occupational therapy practitioners apply integrative medical and social science to activity analysis. So when you're done explaining OT, your listener will understand that you are both medical and social, and that you use activity analysis based in medical principles to help them restore function. Okay? OTPs help medical diagnoses and non-medical diagnoses. And then finally, we are a medical licensed professional. It is a medical degree. Walk in that. Lead with that. I'm an occupational therapy professional. I got a medical oriented degree, right? It is a medical degree. I am classified as a medical professional, a medical provider. When I go into an insurance company, I am a medical provider. I'm a practitioner. That's something to be proud of. Okay. All right. Moving on. Explaining OT to professional peers. So I'll try not to get too carried away here, but I do want to just run through it, all right? So I've had a lot of experiences explaining the occupational therapy POV to other professionals. I've also had a lot of, rejection to my face because people just aren't buying it. So orthopedic surgeons are only recommending physical therapy. Our major orthopedic institution in my area, they only provide physical therapy outpatient for ortho. That's like crazy to me because we are integrative medicine, which means anytime someone has a physical therapy plan of care open, an OT should be present because PTs are reductionist, which means they are great. They are fantastic at reducing the problem, helping the problem, strengthening range of motion, using modalities, but they don't bridge the gap. OTs are gross anatomy gap bridgers, right? That is why our scope of practice is the way it is. That's why we know what physical therapy knows, plus the social model, because physical therapy is great at what they do, but the person has to go home at the end of the day. The person doesn't just need strong muscles. The person needs functional movement patterns and execution during an occupation, which is different. We know this because we study neuro. Where PT studies exercise, we study neuro. And we know the effects of context on neurological based movements, right? Components of movement and how they're affected by context. So when we're thinking about where we fit, we know that we deserve a spot at the table. In fact, we could do it ourselves. We could rehabilitate ortho completely by ourselves and bring them through the continuum alone. But because we're integrative, we love interdisciplinary care. We want to highlight the strengths of every other profession while bringing the client into their life, right? Into their lifestyle. So we bridge the gap between the clinical world and the social world. Orthopedic surgeons are only recommending physical therapy because they think that's all someone needs. But if you talk to your patient, you know that's wrong. You know that that's not all they need. Neurology thinks we only do ADLs. I talked to a neurologist, I sat down and I always ask them what they think first. And I said, so what do you know about OT? And they said, well, you help with like self-care, right? Or you do the arms. Administration and insurance companies believe OTs are only ADLs. We talked about that a little in the last unit. We talked about how insurance companies are saying, or administrations like of skilled nursing and hospitals, they're saying that we only do ADLs when we know that we have to work in a continuum because we learn the exact same restorative principles as physical therapy. So we have to bill for the same things, which we can because we have a code, right? Physical therapy practitioners believe we are only fun activities and folding laundry. I cannot tell you how many times I have heard a physical therapist joke about how to patients, not to me, to patients, when I worked in SNF, I'd hear a physical therapist said, okay, we're going to get done, doing our exercise and getting stronger, and then you can go fold some laundry. No, that is not acceptable. No, that drove me nuts. They make fun of us. Don't let that happen, okay? But that's what's currently happening. Social workers don't understand that we are trained in social science and can help with discharge planning and setting up services for community reintegration. Not only social workers don't understand that we work in their scope of practice, we have elements of their scope of practice, and we could essentially be care managers, right? We can be case managers. They're not understanding that, so they think we're overstepping when we try to fill that role. Because they're not understanding that, we're not being leveraged as a profession appropriately. We could be doing so much more, but instead we're like put in a box because nobody understands that we're biopsychosocial. PCPs are only recommending physical therapy for everything, and other professions are beginning to be recommended for our scope of practice, like I had mentioned about the business managers and the social workers doing functional assessments. What to avoid and what to incorporate. Again, the OT elevator pitch triad. Do not ever explain your profession using functional, meaningful, or occupation to another professional. That ship has sailed. They know, and they don't understand those words, okay? So don't do that. Being the last one out of a plan of care. If you're in home health, even if you're in a skilled nursing facility, you should never be the first one out. Ever. You can touch on anything. You're the only one who can bill for literally everything that's meaningful to your client. You are the only profession who can bridge the gap between their physical needs and their psychosocial needs. Okay? So when I hear in a home health plan of care or a home health contract that somebody is coming in and OT is one of the first ones out because they assessed how they were getting in and out of bed and they were able to get something out of a cupboard and they can get around their house okay and therefore they only need physical therapy, I want to scream because you are so much more than that. Don't reduce yourself to something like that. You know all of the physical performance. You know how to restore every physical performance skill. Did you do a dynamic standing test? Did you do a strength test? Did you get functional movement measurements on fine motor and grasp? Did you do dual tasking assessments? Are you sure that your patient is, they can get from point A to point B in their house, but what if they had to actually think and do at the same time? You should never be the first one out, ever. When I was a DOR and people would ask me, well, I don't know what to treat. I don't know what to do with this person. Like, how can I keep them on caseload if there's nothing else to do? As an OT, there's everything to do. You can do literally anything. And you know the appropriate amount of time that you can do it for. Misrepresenting yourself as an unlicensed activity leader. When you're doing these Pinterest treatments in front of everybody and they're seeing that you are literally planning these non-evidence-based activities, that's why we're getting typed, right? And allowing your role in a co-treat to just be upper body mobility. I This drives me nuts. So I continue, even though I'm in private practice, I continue to work and I continue to co-treat outside of my practice. And I don't understand why every time I go to co-treat, they say, well, don't you want to grab your deck of cards or your cones? And like, they usually reach for cones and stuff, and then I'll, do posture and everything like that. And it's like, no, I am not just the arms. I'm not just cones. Let's get this person up and walking. I'm going to address, postural supports and compensatory movement strategies while you can analyze gait, and we can both work on functional ambulation. I'm working on integrating this individual's movement on a neuromuscular level. You work on body mechanics for that. Both of us are important for that process. Both of us can work on gait and ambulation. We are integrating it. They are reducing it to refine the components. Okay? So we're both needed. We are integrative. They are the parts. We are the whole. Same task, different perspective. So what should you incorporate? Questions to determine what they think OT does before you explain it to them. So, like I said, when I go in and I am about to educate a professional on what OT does to get more referrals, I'm going to say, well, what do you know of OT first? That way I know how to tailor my presentation to them. So always ask where they're at so that you can make it as relevant to them as possible. OT value that would make sense for that profession, again, like I had just said. Correction when a professional misspeaks about what OT does or implies you don't know something. Correct them. That example that I used when my patient told me that their physical therapist told them they shouldn't come to me for foot drop, I called him. I called and asked for him by name, and I said, hey, I am Michelle. I'm the occupational therapist. It's my understanding that you feel as though occupational therapy wouldn't be the right fit for our client, our mutual client. And I was just wondering if we can have a discussion on that. And immediately he's like, oh, no. Like there was it. People do not expect to be called out, and you have to be able to do that. You have to be so confident in your scope of practice, so confident in your skill set that you are able to say, no, I actually do gait analysis as well. I actually integrate movement as well. I actually work on the physical body as well. Advocacy for your own education. So making sure that when you're speaking, you're not taking part in reducing your profession when you're in the presence of another profession, right? Confrontation. So again, don't allow the misrepresentation of your profession, not even once, not even a little bit. It just perpetuates if you don't nip it in the bud. Use the phrase integrative medicine. Speaking up in an interdisciplinary meeting addressing elements of your full scope of practice. So you, as the occupational therapy practitioner, should be leading these meetings. You should be saying, okay, I'm going to look at this, this, and this, and this. If your site is saying you're just ADLs, well, you should go to every interdisciplinary care meeting with a list of non-ADL components that you are competent in that will help that patient and their family members. Just be prepared. Be the person who knows what's going on. Be the person that's bridging all of the professions together. Your clients will see that, and that will speak volumes for your profession. Defensive documentation, we've talked about that, and that's why we have the documentation database on the portal. So doing these things over time will help as far as exactly how to pitch OT using these principles. It's going to be unique to your situation. So what are the biggest takeaways? Restorative function for gross anatomy, that's how they should be. So what should your hearer understand at the end of your OT explanation? What should your fellow professional understand? They should understand that you are restored, you know the means for restorative function for gross anatomy. that you are and address neurofunction and cognition. You work in the biopsychosocial model, which means you combine 3 different professions in one, and that's okay. And then finally, nobody should ever feel like we're infringing on their space, because our profession is uniquely designed to fill that gap. Look at this. Check this out. This is on the bot portal. So we give this to every single one of our patients. Every single patient I have, I sit with them and I educate them on what OT is compared to PT and SD. Notice that we overlap. Notice that we are the largest of the two. But notice how each one has their own specialties, and we respect that. But that doesn't mean we dismiss ourselves from the picture. And that doesn't mean that we give an inch in our skill sets. It means that we have to know and be competent in both of their scopes. Not all of it. Not all of it. Not all of it. They have a specialty, and we respect that and love that. And I defer all of the time. I always refer to chiro, massage therapy, PT, ST. I believe in that. I never give an inch. I say, listen, I think that you should go to speech therapists. I think that you should see a speech therapist, but this is why you need to stay in OT while you see your speech therapist. This is the difference. This is what your speech therapist is going to do, and I think that they do a much better job of that than I. But this is what I can do for you that is going to overlap. But then I'm going to bring another component that speech doesn't have. Likewise with physical therapy. I can do the exact same thing that physical therapy can do. But because of their scope of practice, they can really hone in on it. Whereas I look at the bigger picture, so I have a lot more to address. So you have to see both speech and PT, but you also have to see OT, because I address what they don't. I bridge the gap so that you don't just go to physical therapy, do some ankle pumps, go home, and then you still have the chronic pain because movement was never integrated. Okay, so we are that integrative piece. So nobody should ever feel like we're infringing, because it's just what our profession is. It's just what our profession is. Okay, so number 3, how do you explain occupational therapy to your patients? I talked about this a little bit in the intro. If your patients still think they need physical therapy more than you, we have to revisit how you're explaining OT. So right now, they think that physical therapy knows more about human function than a functional movement expert, an OT. Why do they think that? Because of the way we're explaining OT. Because of how we're carrying ourselves, our verbal and nonverbal communication. What is it that they're hearing when you come in and introduce yourself as the OT who's going to help them get ready? What are they hearing? Think about it. They are not hearing you're a restorative therapist going to help restore movement to their full body. They're not hearing that. They're not hearing that you are going to provide neuromuscular restorative therapy to decrease chronic pain on a neuromusculoskeletal level. They're not hearing that. They're hearing, oh, these people help me get dressed and I just need to go to physical therapy. So now whenever you do a physical-based session, they call you physical therapy to their families, because now they're all confused. They don't know what's what. They think anything that they do with their physical body is physical therapy because no one's explaining OT correctly. So another predicament that we find ourselves in with our patients is they think OT does self-care and other stuff like that. This is what patients actually say. We ask all of our patients what they think OT is before they start their treatment plans, and they think that self-care is what we do. In fact, I have patients calling me, like patient inquiries for a new patient, and they say, so do you guys just do like self-care? Because I don't need help with any of that. It's tough. It's tough. Another predicament, they think OT does not work on gait and lower body. They think OT does not do restorative therapy. They think we don't learn the body, just like physical therapy. And they think that you would only see an OTP if you were a child, had a stroke or another trauma, or you need adaptive equipment, or maybe for a hand thing. That's That's that typification that we talked about, right? And then finally, universal labels. If someone had to attach a picture to an OT, I'm pretty sure they would attach a sock aid. And I'm telling you, I've used a sock aid maybe 3 times in my entire career. Okay, moving forward. Avoid the elevator pitch triad. Avoid phrases like, I'm here to get you dressed. I'm here to get you ready for the day. Irrelevant or undignified treatments. Consider your population. Do not go to Pinterest. Do not capture a pediatric Pinterest treatment and say, now this looks like a fun thing to do with a geriatric population. These people built the country on their back, and you're about to have them decorate socks or play dress up. That is a serious problem, and that is not appropriate. In fact, there's no way that you are going to be able to justify something like that if you were to be in front of a courtroom. What diagnosis would your patient have to justify that? Work on the problem. I would say 85% of my clients that are over the age of 80 do not like fun activities. So fun treatment-itis is the next one. They don't like that. Some of them do, and we post those on Instagram, and you see those. But most of them don't. In fact, we tried to do dancing with somebody, and she kept saying, I don't want to do this. I don't want to do this. Give me some weights. And that's what she wanted to do. And that's why it's important to give them the choice, right? And then avoid always doing ADLs and IADLs. You do not have to do an occupation-based treatment every single time. In fact, you shouldn't even approach self-care unless you know the individual has the appropriate functional capacity, like body function, structures, and performance skills acceptable enough to perform a complex occupation or activity like dressing. So what should you incorporate? Things you should incorporate include correcting your patient when they call you by a different profession. We have patients coming in here calling us physical therapy, and you better believe we're going to say, we're occupational therapy. We're physical medicine occupational therapy. And it's lovely when it goes the other way, right? They say they confused physical therapy with occupational therapy because that's how it should be. We are way more rigorous than physical therapy. Advocating for what OT would look like in the next level of care. So if you work in acute care and someone's being discharged to MRU, or someone's going from MRU to skilled nursing, or someone's going from MRU to outpatient or home care, what should that person expect from an OT at the next level? How can they benefit from OT at the next level? We should always be advocating for our brothers and sisters in other sectors of the OT industry. Always, always, always leveraging what OT can bring to the table and how they would benefit from having an occupational therapy practitioner follow them. Educating on the science and activity analysis surrounding the intervention you're choosing. So explaining research, explaining the evidence around your intervention. What should they expect if they do this intervention because research told you? They want to be an active part of that. So start incorporating that into your treatments. Then, of course, providing handouts for the differences like I had showed you, things like this. Every single one of our patients gets this in their folder. Biggest takeaways, relevant and necessary. So our profession is just as relevant and necessary as any other profession. We do the upper and lower body. We are evidence-based practice, so we're always cutting edge. And then we're integrative medicine. We bridge the gap. So if you are on a treatment plan with another profession, you should also have an OT following your case. Finally, a note of encouragement. Let me just take the time to read this. We went a little bit over, but hang in there with me. Our Deepest Fear by Mary Ann Williamson. Our deepest fear is not that we are inadequate. Our deepest fear is that we are powerful beyond measure. It is our light, not our darkness, that most frightens us. We ask ourselves, who am I to be brilliant, gorgeous, talented, fabulous? Actually, who are you not to be? You are a child of God. Your playing small does not serve the world. There's nothing enlightened about shrinking. Nothing enlightened about shrinking so that other people won't feel insecure around you. You are all meant to shine as children do. We were born to manifest the glory of God that is within you. It's not just in some of us, it's in everyone. And as we let our own light shine, we unconsciously give other people permission to do the same. As we are liberated from our own fear, our presence automatically liberates others. That is the occupational therapy profession. That is OT. We've spent so many years hiding our full scope of practice in fear that someone's going to call us out, in fear that they'll think that we're overstepping, in fear that we may do something wrong because nobody knows that we do this, so maybe we don't actually do it. We've spent so long putting our strengths in a box and giving ourselves restrictions because nobody's done it before. So what would happen if we actually walked in our full scope of practice? What would happen if we gracefully communicated that we can do that too? And we can do it with you. What would happen? What would happen if we took the lead on this? If we actually stood up and said, well, I'm physical medicine and social medicine. I do cognitive therapy and physical rehabilitation. I do what all of them do, but I go a step further and I make sure that it's applicable to your everyday life. What would happen if we just stood up and said, I can bill for therapeutic exercise because I went to school to learn restorative therapy, and evidence and research says, because I'm autonomous and you can't tell me how to bill, because I am an autonomous medical professional and you have no power over what I do with my patient, because if something goes wrong, it's on me, not you. Because I went to school for this medical degree, I have to do therapeutic exercise and neuromuscular reeducation before I do self-care. I am not just self-care. I am everything before that. And I will injure my client if I jump right to doing anything that falls under this code. What would happen if you just stood up for yourself and explained this? What would happen if all of us wrote a letter to the insurance companies saying, this is what our occupational therapy profession is? Because we can't depend on other people to do it for us, because clearly that's not working. So what would happen if we started explaining it competently and reaching out and having those conversations? Would our relevance and competence and respect increase? I don't know.
Now that you have watched that particular training, let's talk about your action steps. Take time to copy the following quote into your journal or into the space provided below. Think about these words as you write them. When you are finished, say them out loud to yourself as if you are hyping yourself up for a big game. This is the big game. This is the rest of your life. This is your profession. This is how you're going to provide for your family and for yourself forever. You should want to have that be the best case scenario. So speak this truth into your own life. Write it, read it, say it over and over and over again. This quote is yours. Write it out, get a poster, put it on your wall, do what you need to do. But know that we've been taught to be insecure and lack confidence for our scope of practice. We've been taught this by academia. We've been taught this by professional organizations. We've been taught this by this reduction mindset of the occupational therapy profession by other professional peers. You are not inadequate. You have the skills necessary to literally lead the medical industry. Several years ago, the United States tried to integrate medicine. We tried to get on the same page, but there was a lot of pushback for interdisciplinary approach to care. We are the definition of integrative medicine. It's our turn to lead the way. It's our turn. OT bridges the gap. Guys, we are the example. We are the ones. We're the ones to step up onto the stage where half the room is a social medicine conference of social workers and mental health practitioners and community-based practitioners, and half the room is specialists and physicians and doctors and nurses. The biomedical model and the social model in one conference, in one room, and we are the ones to teach them how to work together. It's us, because we are that. We see the importance of everybody because we are everybody, and we're good at it, and we can help. We can help lead this. But first, we have to throw away inadequacy and imposter syndrome, and we need to embrace the fact that when we let our light shine, we unconsciously give other people permission to do the same. As we're liberated from our own fear, our presence automatically liberates others.